health and wellness. We have 3 presenters in this section, and that are looking at a combination of not just physical, but also emotional and mental well-being and surveillance. And so to kick it off, we have Bailey Lockwood, and her presentation, Who Counts? Investigating the Invisibility of Native American Women with IDD and Health Surveillance. Bailey, I will turn it over to you.
Great, thank you, JC. It's a pleasure to be presenting with you all today. Can everyone hear me all right? Awesome. So this project really made up my thesis research for this year as part of my honors capstone to graduate here at the U of A. And in this research, I investigated the representation of Native American women with IDD in major data systems like the census. This work is part of a broader project aiming to increase the cancer screening rates of Native women with IDD through a community-informed adaptation of a cancer screening curriculum. This broader project is funded by the Partnership for Native American Cancer Prevention and led by Dr. Julie Arman here at the U of A and Dr. Heather Williamson at Northern Arizona University. So really the basis of this broader project is the idea that previous research has shown that Native American women receive cancer screenings less frequently than white women, and women with disabilities receive cancer screenings less frequently than the general population of women. And this is true for both the pap smear and the mammogram, which you can see in these graphs here. Therefore, there's likely this double burden of cancer screening disparity for women who are Native American and who also identify as experiencing disability. However, the research team's efforts to identify this disparity in the data shows that actually very little data exists about the population of Native women with IDD. In fact, our research team to date has not even been able to find a population estimate for this group of women, let alone information about their cancer screening rates. This background led me to my guiding questions for my thesis project, which was a sub-study of this broader cancer screening project. First, I asked, what are the factors that shape the invisibility of Native women with IDD in major health surveillance systems? And an important and related question is, what does data justice look like for this population? And how do we begin to create a more equitable data landscape? In pursuit of these questions, I completed 11 semi-structured interviews with a variety of scholars and advocates who work with the population of interest. These advocates and academics come from a variety of different fields, but what really unites them is their dedication to serving this population. I wove interviewee stories together with secondary literature and primary data analysis to create a picture of invisibility for Native women with IDD. And here in the top right, you can see the 3 major themes that were generated from these interview testimonies. On the one hand, participants discussed how surveillance frames that exist in current data collection mechanisms really tend to exclude intersectional populations. Many of us probably know that surveys like the census don't really capture people with IDD right now. But also it's important to note that even IDD specific surveys like the National Core Indicators do not capture Native American women with IDD. They don't capture this racial ethnic intersection. Another major theme was structural barriers to being seen. And this really primarily manifested in the service system. The disability service system serves as a major source of data on people with disabilities, but interviewees talked about several barriers to accessing services among Indigenous communities, affecting our population of interest. And finally, interviewees discussed how Eurocentric epistemologies that guide surveillance really tend to obscure different Indigenous community perspectives. For instance, Indigenous communities may not have classic Western definitions or understandings of disability. And so when functional or biomedical parameters are used to identify disability and health surveillance, it really obscures this Indigenous community perspective for these different populations. Overall, the study attempted to broadly characterize the factors that prevent Native women with IDD from being captured in data systems. And future analyses plan to focus on data justice, or how we take this newfound knowledge to create interventions to increase the visibility of this population. Ultimately, this project is founded on the idea that every person has the right to be seen on their own terms, which is a key tenet of self-determination. And I just want to thank my committee advisors on this research, Julie Arman, Heather Williamson, and Dr. Janelle Lamoureux from the School of Anthropology. Thank you.
Thank you, Bailey. Does anyone have any questions for her? We'll marinate on it, add it to the chat box, and we'll get to it during the discussion for this section. Next, we have Ginger Mogul, who is one of our certificate students, to present her poster on early dementia screening for adults with intellectual disabilities.
Hi there, thank you. So for my community experience, I was working with Dr. Yumi Shirai at Artworks. And one of the tasks that I had was to conduct the early dementia screening tool on all of the artists there. And so the tool that I used was the NTG EDSD. And so the NTG is the National Task Group on Intellectual Disabilities and Dementia Practices, and the EDSD is the Early Detection Screen for Dementia. And so what this is it is a 6-page form. It's filled out annually by, excuse me one second. It's filled out annually by a family or other caregiver member, usually someone who knows the person well. It can be completed in about 15 to 60 minutes. Something to note is that this form is not a diagnosis. It really just tracks changes and kind of shows you what the person started out with, any unnatural signs of aging, and what makes this one different between the dementia form that's used for the general population is that this form asks if symptoms have always been the case, if it's always been the case but worse, or if it's a new symptom in the past year. And so the ones that are given to the general population don't do this. And so some problems that I had when I was just beginning to conduct it, I only got to do one because everything got shut down after I finished the one. And so some problems that I had is that I did not know the artist that well. And so I had to talk to a lot of the staff to get information and make sure that it was accurate. And so that's some of the problems that we see with diagnosing dementia in this population, is that other conditions can mimic dementia, and that the turnover rate for caregiving is so high. So you might not have the staff that know the person well enough to document the changes properly. But it's really important to have this written record. That way you have this detailed description to give the doctor. You know, you can be taken very seriously because you have everything laid out very detailed for them. And I think that is all I have to say, so thank you.
Thank you, Ginger. Does anyone have any questions?
Do you hope to, once it's safe to get back on campus and everything, do you hope to continue looking into this or to inform someone else's study of this?
Yeah, for sure. I'm gonna graduate this May, but I was really looking forward to doing this for everyone. I was interested because you get to know everyone really well. It's pretty comprehensive. So yeah, I hope to tell more people about it in the community. I had no idea about it. I have a family member with an intellectual disability. I have dementia in my family. So it's something that's relevant to me. So I definitely, for sure, would like to continue talking about it and perhaps continue finishing my work. Thank you.
Wonderful, and congratulations.
Thank you.
Thank you, Ginger. Okay, so for our next presenter, we actually have Victoria Rodriguez, and she'll be presenting an adaptive narrative quality assessment for examining grief experiences expressed by individuals with intellectual disabilities.
All right. So as the title suggests, this summer I had the opportunity to explore a novel form of assessment for examining grief experiences of bereaved individuals with ID. Unlike earlier theory, which assumed unawareness or inability to understand loss, recent research has shown that individuals with ID experience bereavement just as the general population, but face communication barriers with caregivers, and the use of standardized grief assessments can easily lead to misdiagnosis and disenfranchisement of these individuals' grief. Furthermore, current grief theories highlight the need for individuals to be able to share their experiences with others in order to overcome their bereavement. But interventions are often inappropriate for this population because they assume participants have traditional verbal and written communication skills. So there's a clear need for appropriate assessment and intervention for bereaved individuals with ID. And so working with Dr. Yumi Shirai, I was able to build upon the concept of needing to share one's experience. And we chose to explore narrative skill as a potential basis for an assessment. Narrative quality has been shown to allow for inferences about an individual's processing and understanding of an event, meaning that the greater an individual's narrative quality in the sharing of their experience, the higher understanding and processing can be assumed. As part of a pilot study for a grief support group for individuals in this population, intake interviews were conducted, including the facilitation of a standardized grief assessment. And we believed that assessing the narrative quality of the participants' responses to the items on this assessment could inform our understanding of their understanding and processing of their grief experiences, and could hopefully tell us a little bit about the level of grief they were experiencing and more about their unique treatment needs. So we utilized an existing narrative quality assessment originally intended for assessing children's storytelling skill, which broke down narrative skill into different elements such as character, setting, temporal markers, pieces that made up the quality of their storytelling skill. They scored quality according to the individual child's use of these elements in their story. So for this project, 2 researchers independently applied this original assessment to an audio-visual recording of a single critical cases intake interview. And when we then met to discuss appropriate adaptations for our context and population. So preliminary findings showed that certain elements that were significant within a storytelling context were not as significant in this question answer context, and also showed that some of the scoring criteria that was part of the original assessment were not as appropriate for our population. So for example, the use of temporal markers was scored according to individuals' utilization of specific terminology, such as next, then, etc. But such markers were found to be less significant in this context, and were not as necessary for the construction of a quality narrative response to grief assessment items. And thus didn't need to bear as much consideration for our purposes. Also, if we choose to consider something like temporal markers, the fact that it's being based on specific use of particular vocabulary, which may not, it was seen as being potentially inappropriate for our population, and the scoring was adapted and adjusted to include any articulation of timing rather than particular vocabulary. Most notably though, we found prompting as a critical narrative element in our context. Prompting by asking grief questionnaire items was what created a foundation for participants to construct their narrative responses upon. And further prompting for things such as clarification or connection to the individual's personal life was seen as essential to encouraging more valid responses. So we chose to add the element of prompting to our adapted assessment. And while this is just a beginning stage, we're just starting to understand how narrative quality might help us assess in this type of population. We believe it's very important because it's progressing towards a better understanding of these individuals' grief experiences, improving assessment and interventions for them, and hopefully opening a door to more inclusive research through understanding how to better engage this population in more in-depth data collection. And that's what I got.
Thank you, Victoria. Any questions?
Yes, please, JC, this is Lynn.
Yeah.
I'm curious about the context of your thinking here, in the sense that I wonder, I know you only had one individual in your thinking about the problem. I wonder if you felt or feel that it would be necessary going forward to make this be one tool of many assessing this individual, whether you found any sense that the behavioral consequences, whatever caused this person's grief, did that ever result in higher prescription of psychopharmacological tools to control the behavior? I'm interested in that context and how you see this being used, and whether that psychopharmacology might affect an individual's ability to use this kind of document for assessment.
So that was actually, there's a lot more background obviously than 5 minutes allows, but that was one of the pieces that really inspired what we're looking for in a different form of assessment, because so often there is misdiagnosis due to behavioral reactions, and behavioral reactions being how someone communicates their grief rather than verbally stating it. And a lot of this misunderstanding can come from that standardized grief assessment where there is question answers, you know, on a Likert type scale, and even open-ended questions. We're seeing a lot of misunderstanding of the question itself, and the responses being almost people-pleasing is one of the things we've seen, just trying to give the right answer that is wanted. So we're kind of looking at expanding. Yes, we want to get a larger sample. We want to apply it to more individuals from the same pilot to get an idea of more feasibility, but also start working on a scale, not only of, okay, high quality shows higher processing and understanding, but also how it can be compared to other standardized assessments so that we can get an idea of what these different levels of quality could be comparable to different symptomatology standardized scales, and just hoping that this is almost like a back door, so we can take any response we get and get a little more information from it with this assessment. And while we don't have that scale yet, we're not sure exactly how to apply it just yet. One thing we are hoping to do is to do kind of a pre-post and use it almost as a resource, hopefully in any situation that has interviews and interview questions, so that we can at least get change scores and use it almost as a program evaluation tool to see if there is a change after an intervention. So we don't have an answer for pre-intervention yet, other than deeper content understanding, but hopefully just to see at least if an intervention is making a difference for an individual. And these are just first steps, but yeah. Sorry, is that too much?
No, we have another question for you, Victoria. Cool project. Are you planning to take this research further in grad school?
So yes, very much so. I'm actually currently working on my master's thesis. Hopefully will be done in the next month or so. I would love to move on to my PhD project, which hopefully will also be expanding on this. Currently, I'm looking at a content analysis of our critical cases entire interview and really breaking down, first and foremost, the role of prompting that occurred, because we believe that prompting could be an essential tool for, we have these standardized assessments and they're great for many reasons, but with the misunderstanding, we want to use prompting as a resource to really help get more valid responses and get more inclusion of these individuals, both in assessments, but also in research, so that we can get a better understanding of the population as a whole. But also moving beyond just this particular population in a grief context, expanding the idea of what grief means, expanding the idea of what communication and expression means, looking at different forms of expression, and potentially in different contexts, such as children with chronic illnesses, different populations. So yes, lots of planning.
Great, thank you.
Thank you.
We're at the Q&A, and I know we've already been having some discussion. I want to get back to, there was a question in the chat box for Bailey. If you had to pick one of those areas you identified as the most significant barrier, which would it be?
So thank you, Dr. Oland, for this question. I think while all the barriers that were discussed by interviewees really play out in this phenomenon of invisibility we see for this population, Native women with IDD, I think the most kind of systemic problem is going back to the Eurocentrism that is embedded in data systems. So for instance, the idea that really surveillance methods like BIRFIS or the census or the American Community Survey, traditionally they were based on biomedical disability outcomes. And still they are based on functional outcomes, but neither of these paradigms necessarily fit the community contexts of these women that we're talking about, which are very diverse and differ from community to community. However, we found that these women tend to, in order to obtain services, have to subscribe to these Western paradigms of disability in order to obtain services and to be correctly, in the Western sense, identified as having a disability. So this really creates an issue of negating Indigenous worldviews and ways of knowing, and how these women that we're talking about might fit within their own community context. And so at a really systemic level, I think that is one of the biggest barriers to being seen for this population.
Thank you. Any other final questions for this group of presenters? Great, all right, thank you all.